You matter. Your health matters. You deserve not only good quality care from your individual providers, you deserve that. You also deserve research that reflects your real life lived experience, and you deserve a public health infrastructure that reflects your lived experience and your needs as a member of society.
Welcome to the ZAMI NOBLA National Organization of Black Lesbians on Aging podcast. We are your sound source for Black lesbian herstory. I'm your host, Angela Denise Davis.
My name is Tonia Poteat. I'm a Black queer Southern woman. I show up in the world as a healthcare provider, a researcher, and a social justice advocate.
Well, it is such a pleasure to have you on the ZAMI NOBLA podcast. Tell us a little bit about how you got to where you are now as a researcher in your specific arena.
I grew up in a small town in North Carolina. I have always been fascinated with how the human body works and also been very concerned about justice and fairness. And I think that has led me down multiple paths, both in the medical care arena as well as in the research arena. Mm-hmm. I was the first person in my immediate family to go to college, and that was quite an experience. And I really didn't think much about a career in research or anything like that. That wasn't really in my purview. I didn't know anybody who was a researcher or an academic. It didn't seem like it was something that would be part of my life. Mm-hmm. But after I got out of college, I worked for a few years at the Feminist Women's Health Center in Atlanta, and also at an organization that delivered meals for people living with HIV. And I realized that I wanted to provide more direct healthcare services. I really like people. I liked engaging with people, and I liked the social justice aspects of addressing HIV. So I returned to school and got a physician assistant degree, mm-hmm. and did National Health Service Corps, which is a federal program that pays your tuition in exchange for working in an underserved community after you graduate. And I ended up, much to my surprise, I was sure I would end up in a southern city somewhere, but I ended up in the Lower East Side of Manhattan, working in a methadone maintenance program. It was such an important learning experience for me, mm-hmm. That has affected my life and continues to affect my life in ways that I would not have anticipated.
What did you learn most from that experience?
I learned, I didn't know anything about addiction. I didn't know anything about drug use. I knew that my mother always told me not to use drugs or I was going to die. I remember those commercials, here's your brain on drugs. But I didn't know anybody who had struggled with addiction. I didn't know anything about treatment for addiction. Mm-hmm. And so working in that job, I had an opportunity to build relationships with my patients who had all struggled with addiction for a long, long time, and to learn about what treatment options were available and not available for addiction, and also to get some understanding of the social circumstances that lead to dependence, mm-hmm. and the stigma and shame associated with certain kinds of dependence. And all of that was incredibly important in not only the specific arena of substance use and how it relates to HIV, but also in just building empathy around how each of us struggles with different things in our own ways and tries to seek support and help the best way that we can.
So growing up as a kid, you never thought you would be a public health rock star. And I can say that boldly because I know that's what you are, even though you're far too modest to admit it. But you've done some really amazing work, especially in the area of trans health, and done things really globally, looking at some of the most important medical issues within that arena. Talk to us a little bit about the work you've done with trans health.
I first learned about trans health issues when I was living in New York. I volunteered at the LGBT Health Center because I wanted to be with my people. And every second Saturday of the month, I think it was, they had Trans Health and Education Day. And that's where I learned about providing healthcare for people of trans experience. I met trans individuals. I expanded my mind. Again, it was another arena where I knew very little about transgender people, about transgender issues, and had never really given it much thought, honestly, and had the opportunity to really get to know people as individuals and also make that connection between their individual situations and the social and structural environments in which we live, which is another key aspect. So I did that work while I lived in New York. Then I moved to Atlanta and worked at Grady infectious disease program and became one of the few people on staff that had that kind of experience. So I ended up providing care for a lot of transgender people living with HIV there. When I moved to Baltimore to get my PhD and I worked at a community health center there that was also LGBT focused, I continued to provide care for transgender people, both living with HIV and not living with HIV. And as I was thinking about how to choose a topic for my dissertation, I wanted to choose something that mattered to people, that would be useful, and that came from my experience. And as I thought about that, and also that I could be interested in for several years, the process of...
That's very important.
Yeah. And I volunteered at the time also with the organization called the Transgender Response Team. That was a group of community leaders that gathered monthly and worked on issues related to the social drivers of health disparities. So housing and homelessness, stigma and discrimination, healthcare provider competency, those types of things. And it was through my work, both in the clinic providing medical care and volunteering for the Transgender Response Team, that I thought that what would be really helpful for me to understand that I would be interested in and also useful to the community was to document what people's experiences of accessing care and trying to access care were like. And also to understand from healthcare providers' perspective, what were some of their challenges and barriers when they encountered transgender patients and in the context of providing care.
You know, we are in Atlanta, Georgia, and I tell people oftentimes that we are the buckle of the Bible Belt. And as I hear you talk about the work you've done with individuals who are transgender around issues of health, I can imagine that there may have been some pushback or some people who didn't fully understand the value of your work, in particular helping this community. Did you experience any particular bias that made it difficult for you to do the work that you were doing here?
Yes, in surprising places. You know, I was at Johns Hopkins, which has a long history of, or an old history, I'd say, of having started the first gender clinic in the United States and then having closed it down, and really some of the leadership at the time in the School of Medicine being very anti-transgender. So people thought that the institution itself would put up barriers. But in the School of Public Health, where I was located, I really didn't have any barriers. People really weren't familiar with transgender health and couldn't provide support, but definitely did not provide barriers. Interestingly enough, someone on my dissertation committee, however, you know, I had done my public presentation, and then you go into a room where you answer questions for an hour, and it's sort of your exam to see if you pass your dissertation. And one of the questions I got is, did I think I would ever be able to get any work doing this kind of thing? Because no one was interested in transgender health.
Wow.
And that was a shock. So I think the public face was one of, we will present no barriers, we support your work. But I think the internal thought was, this isn't meaningful work.
Well, you've certainly proved them wrong. Because you've done so much work, not just here in the States, but like I said, internationally as well. When you think about the work that you have done in dealing with transgender communities outside of the U.S., what things can you say are similar, and what are some differences in the healthcare access, in the social environment, and just in any other way you can identify?
I've been struck by how similar the experiences of particularly trans women has been. Most of my research has been with transgender women. And the stigma, discrimination, and violence that they face all around the world is unparalleled, I think. Just like we know there's global anti-Blackness, there is global stigma and discrimination against trans people, even in settings where people assume there's more accepting environments. The day-to-day lived experience of most of the trans people that I talk with is one of struggle. There are some privileges that help certain people manage that stigma discrimination, but it's very, very common. And I think some of the differences I've seen in the work, like I recently completed data collection for a study in South Africa, and I think some of the differences I see in smaller areas or more rural areas is whether or not people have community, whether people have had the opportunity to find one another and organize and develop a supportive community.
In addition to community, because that segues into another question I had, and I would see that just based upon what you said as a way of combating the barriers to access and the barriers to one's ability to thrive within these communities. What other things are needed to break down some of those barriers, in particular to healthcare access?
That's a great question. I think some of the more obvious things we need are empathy. Unfortunately, I think medical training doesn't necessarily do a great job of helping us build empathy. One of the findings from my dissertation research was not shocking that we all want our healthcare providers to listen to us, to respect us, to treat us like we have value, and to respond to our needs. And shockingly, that's also what trans people want when I talk to them about what their healthcare experiences were like. So I think the more providers have the capacity to do that, the better I think care will be for trans people and for everyone else. I think we can also do a much better job of providing information and education for healthcare providers during their training so that they don't see a transgender person and have no idea what to do, including not knowing what words are respectful and not, because sometimes people don't even know. They're not intentionally insulting. They just don't know what respectful words are.
Right.
Being familiar with the variety of ways that people's bodies can be. Just those basic things, I think, would go a long way.
It's interesting you talk about that piece on empathy and doctors not really being trained in that. I mean, it's kind of like a friend of mine who's a physician who says that doctors really aren't trained in nutrition. And some of these things are quite basic. And you would think that they would be a part of a medical curriculum that makes it possible for doctors to see people of all sorts of demographics as being human and needing some very basic things. I think it's also interesting for you as a Black lesbian to be in this role and doing this type of work. And I say that because I understand that public health is not just about someone seeing a doctor in the office. It's about all of those social environments and those opportunities for community that really makes it possible for people to be healthy. And one of the things I know is clear, there is a lot of energy within lesbian community specifically about trans issues. How has your role as a Black lesbian affected the work that you do, in your estimation?
I think it is part of what helps me to connect, to be honest. I mean, the esteemed Stacey Abrams talks about being a Black woman not being a deficit, but being a gift and an asset that we can use. And I feel like being a Black lesbian doing social justice work provides me with a lens that I can choose to use, but that I choose to use to be able to see things in a different kind of way. So, for example, if I go to a meeting, there's recently a research planning meeting where there was this organization that had a lot of money available to do research studies. And they wanted to do research studies with Black gay men to address the HIV epidemic. And I look around the room and I was the only one of 2 Black people in the room. There were no men in the room, and there were no gay men in the room. And I was like, we can't make decisions about what is needed in terms of research for people who are not in the room. And I think having been in situations myself where I felt like organizations and communities and leaders felt like they knew what was best for me or for my community, provided a lens that allowed me to see what was missing. And I don't know how it didn't occur to the other people in the room that was, to me, just an insane approach to
right,
to trying to develop a response to a life-threatening epidemic in a community is to have a meeting without anybody from the community there to plan the way forward. And I think having experiences at the intersection of those multiple identities helps me to be able to see those things. And of course, I'm not perfect at that. There are times that I stumble like everyone else.
Well, you know, the word intersection and intersectionality was another question in my list, in my mind, because all of what you do and the populations you work with, intersectionality is such a key aspect that you just can't do one thing or look at one aspect of someone's demographics. You really have to look at the whole of it to provide best opportunities for folks in whatever field. But certainly, I think as we're talking about public health, and as we think about another population that you're really devoted to, Black lesbian health and the research that you've done there, I want us to kind of segue into a conversation about some of the ways in which Black lesbians are left out of public health research, what you have been doing to make a contribution to that arena, and how we can encourage women who may be a little afraid of participating in research to make a contribution to the work that's going on.
Thank you for asking me that question. It's so important. In my recent efforts to do some research around breast cancer experiences for Black lesbians, you go to the published literature and you see research on Black women or with Black women, and you see that almost none of the participants, either they don't ask questions about sexual orientation, or very few of the participants identify as anywhere along the LGBTQ spectrum. Then you go to the literature on lesbian health, and you see that very few people identify as Black or African American. So you have this whole gap of knowledge about the healthcare needs of our communities. And it's really difficult to advocate for services and for justice without any information. And the only way to get that information is if people are willing to share their stories. And I understand there is a long history of exploitation, very well-earned distrust of medicine and public health in our communities. And so I think it's good to interrogate, who is the researcher? What is their goals? What's going to be done with my data? Those are really important questions to ask. But in order to ask those questions, you have to get in the arena, right?
Right.
Ask those questions. And if you're satisfied with the answers, be willing to share your stories so that we're not invisible in the public health literature. So people know that we're here. They know what our issues are, our strengths, our assets, as well as our needs. And participating is key to doing that. What
is some of the research that you've been doing? I know that there's also been some great work that you've done in partnership with ZAMI NOBLA, but you've done some and are doing some things as well. Let's talk a little bit about that.
The project that I'm working on now, in partnership with researchers at Johns Hopkins and with ZAMI NOBLA, has been just amazing. The current project is engaging women who've experienced an abnormal mammogram or a breast cancer diagnosis about their experiences of care. Because it's hard to get the treatment you need if you're not engaged in care. And so understanding what are the barriers to engaging in care and what are the facilitators, what things work well, so that when we're giving advice, recommendations, advocating for services, we know what Black women themselves say they want and need. And that study has included qualitative interviews. So these are like hour-long conversations about people's experiences, as well as quantitative survey. So, one question with a bunch of answers that you select from.
Okay.
And both of those pieces of information are going to be really critical because some researchers respond, or public health people respond to numbers. So we need those quantitative data, and some respond to stories. And I think it's ideal to combine both. the numbers and the stories.
One of the things we want to do is certainly continue to make women aware of the opportunity to contribute to that research. And so we'll be sure to include in our show notes ways in which women can find more information about that opportunity. In addition to, I guess, the professional work that you're doing and all the wonderful research that you've done and are continuing to do, I guess I would like to segue into a conversation about how you make it possible for you to show up in the world, do all that you can do. That may be a conversation about self-care. It may be a conversation about how, as Black lesbians, we can do things that make sure we are promoting our own health in best ways possible. I know we were teasing before the interview that a lot of sisters say, hey, I don't have time to go to a doctor. You know, I'm too busy to stop. What are some of the best ways that we as Black lesbians, knowing that there are a lot of stressors and there are a lot of things we're responsible for, and we have to hold up, half the sky. What are the ways in which we can promote best health practices and really be committed to showing up as fully as we can?
Oh, there's so many things I'm thinking of. I think the base has to be loving yourself and knowing yourself. Sometimes when I'm about to say something to myself, I think I pick someone that I love dearly and I say, would you say that to this person you love dearly if they said their tooth hurt or their leg hurt or they had some unmet need? What would you say to that person that you loved? And reflecting that back to yourself, someone that hopefully you love or can learn to love. Knowing what your needs are. I know for myself, I've learned that community is essential to me. I need other people with shared experiences in my life. I need to feel that connection to feel whole and to feel well. And so making sure that I reach out, no matter how shy or insecure I might feel in a situation, reach out for community and connection. I know that I'm a person who experiences low energy and depression in the winter when it's dark and it's cold. And so how do I organize my life so that I can provide myself with the care, the extra care that I know I'm going to need at those times of year? How do I plan for visitors or make visits so that I have that sort of nurturing community around me when I'm going to need it the most? Can I look at my work and shift what I do to the times of the year when I have the most energy? Make sure I, try to make sure I get enough sleep, make sure that I eat well. And I developed a Tonia's hierarchy of needs.
Okay.
Right. It's not that fancy, but when I think about there's too much going on, there's so much I need to do. I have this project and this deadline and this person I'm supposed to call and this person I need to do this for. I think about, okay, what is the basic essential thing that you need? You need to sleep. You need to eat. You need to exercise. And for me, exercise is also very critical. So if I don't have time for all three of those things, sleep is going to be the most important. If I have time for two things, then choosing to eat something healthier that might take a little longer to get or prepare is going to be the next thing. Or eating as opposed to skipping a meal. And then if I have time for all three things, it's the golden triumvirate of life, right? But I know those things about myself, and I know that I function horribly on no sleep. I know that if I eat only French fries for breakfast, lunch, and dinner, I feel terrible. And I know that I'm grumpy when I don't exercise.
Well, it's very interesting because we can know things about ourselves, but sometimes we can put such a guilt trip on ourselves when we do it. Like, if I need a nap, I used to feel really guilty about saying, I just need a little nap. Like, why do you need a nap? We talk ourselves out of doing the thing we need to do in order to best perform or show up in the world. So I love the way you talk about, being honest and real with ourselves and knowing it and doing it because we want to show up as optimally as possible.
And who is that voice coming from, right? So I also am somebody who it's great if I can just get a nap sometimes. Sometimes when life is just overwhelming, I might not be physically tired, but I am emotionally tired. I would sometimes go and like sleep for an hour and feel really guilty about it. Like I couldn't tell anybody about it. And I was once talking to a friend about it, and she said, and I expected her to shame me because I was shaming myself.
Right.
And she said, what a great plan of self-care. How wonderful that you do that. And I was like, it is? It's not bad. Yes. I shouldn't be embarrassed that I'm doing this. And she's like, no, this is a great thing that you're doing for yourself. Right. And she was a therapist. So I thought, well, she must know what she's talking about, right? So it can be really helpful to support one another in our efforts at self-care too.
Well, I think there needs to be a public health project that says take a nap once a day and you'll be okay. You know, I mean, I really do believe in that, and giving ourselves what we need and being honest and saying it's okay. And we don't need to shame ourselves for it. The thing that you said, and you've said continually throughout our conversation today, has really been the word community and the importance of community, especially as it surrounds issues of self-care. And I know as I've reflected on the research that's been done that you've been a part of, particularly around breast cancer and lesbians, there is a real need for us to have community and to be honest and talk about what that experience is for so many women, because I know of women who are afraid, deathly afraid of talking about a breast cancer diagnosis or ashamed of their experience. And it seems as if they could talk about it or had some community to be in conversation about what they're going through, that would be so helpful to their health.
I think so. I'm not sure what comprises the shame and stigma that people associate with the breast cancer diagnosis, but you're absolutely right. It's certainly there. It came up repeatedly in the qualitative interviews that we did with people. And part of why I'm so committed to this work is I remember, this was years ago at this point, I felt like everyone I knew had a breast cancer diagnosis. And I sat down and I said, okay, just make a list of all the women you know who've had a breast cancer diagnosis. And I literally fill the front and back of one page. And I'm not talking about my patients. I'm talking about my friends, my community.
Wow.
And I thought, this makes no sense. And it's one of the things that inspired this study. And then I think about, do those women know each other? Are they connected? Do they have community? Do they have the support they need? And for the people that I was fortunate enough to be in close physical proximity to and could provide support for, were often quite isolated and didn't want other people to know. And I think about, the research that's been done on the positive hormones that our bodies produce when we are in loving, supportive, connected relationships with other people, whether it be larger communities or individuals, and how beneficial that could be for someone's well-being rather than like sort of shame, stigma, and isolation. And that's one of the things we want to figure out how to do. How do we help people get what they need, what's going to help them be better, get what they want, support one another, address the stigma and shame. There's no stigma. There is plenty of stigma, I guess, because people are experiencing it, but there shouldn't be. There shouldn't be stigma for any health condition. There should be support and where possible treatment and community if you need and want that.
Yeah. So there's a lot of work we have to do.
So much work.
You have done, speaking of work, you've done work in a lot of different areas, but I'm just curious if someone were to come down from the almighty heaven of research funds and say, Tonia Poteat, Dr. Tonia Poteat, we want to provide you with an unlimited resource to do research in a chosen field. What would that work be? Who would you be doing with? What would that look like?
Oh my goodness. Unlimited resources?
Unlimited resources.
That's amazing. Yeah. I don't even know where to start.
I know. It's exciting.
It is very exciting. Let's imagine that, right?
Yes.
I don't know that I would choose any particular group. I feel like unlimited resources, I could choose all groups.
You could.
I could choose all groups and understand. I think I would always start with that qualitative aspect, understanding from people themselves what they want and need, how they think research dollars should be spent, what questions they have that could be answered. And then I think the second piece that people often don't see happening is then translate that research into something that makes a difference in their lives. And those are other research questions. So now that we understand, so say you get to a full understanding of an issue and a problem, then the next step is to understand how to respond to that and to create these interventions or these support systems or whatever kind of thing the community has said that they needed, and see if that actually works, if that makes things better. And if it doesn't make things better, try something else.
So I sense that you really have a real love for being able to do research, as I'm saying, from the ground up, really being concerned about what the people need as opposed to maybe what those in the academy think the people need.
Absolutely. I had a great conversation with a friend of mine who's a sociologist. And there's a lot about sociological theories and understandings of how the world works that I think are important and are really fascinating. And we had this conversation about why she's a sociologist and I'm a public health practitioner. And she loves the ideas and understanding and the ideas. And she feels like then that information can go out into the world and people can use that to make change. And I am so practical. I'm just like, so those are great ideas. So how do they apply? What are we going to do with these great ideas to make a difference in the lived reality of people? So I think one of the reasons I love public health is it provides, as a field, the opportunity to pull together these academic ways of understanding the world and to use them to really make people's lives better.
This may sound very uninformed of me, but I think probably it's only been within the past 10 years or so that I've really come to fully understand what public health means and its importance. And I think I'm probably not alone in that because I'm not for sure people really think about public health. I think that we may think about health, but how all of those intersections meet and the different demographics and what it means to talk about health in a much larger way, people don't think of. I may be wrong with that. But just for the person who is kind of like me 10 years ago, how would you define public health and its importance for us today?
That's a great question. I'm going to answer it with what might sound like a random story, but I feel like it's the key story for public health. If you graduate from a public health program and you haven't been told this story, they've done you wrong. Okay. So it's the story of how there was a cholera outbreak in a community. You probably heard this. John Snow is a famous public health person. And people had all sorts of theories about why there was this horrible cholera outbreak. And of course, individuals could go and try to get treatment for the cholera outbreak. But there was more and more still cholera. And John Snow did research in the community and figured out that there was this one water tap that was being used by all the people who developed cholera. And he changed the water tap. And there was no more cholera. So to me, that is public health. It's one thing to try to stem the tide of poor health on the individual level, which I love doing as a healthcare provider because I love people and I love that individual interaction. But the beauty of public health is that you go further upstream to where the source of the problem is. And if you can fix that source of the problem, then there's much less need for one by one individual trying to manage conditions because you've addressed the source. And that's what public health has the power to do.
Is there a social justice component of that? If you say that some communities have better faucets than others, and we may think that it may be more important to serve this community with better faucets than the one across town?
There is nothing but social. I don't understand how someone can be a public health researcher and not also a social justice advocate, right? Because we know that health conditions and poor health are not evenly distributed in our societies, right? And I don't know how you're living and breathing and not knowing that uneven distribution is about power and about justice. And so to me, social justice and public health are inextricably linked, right? So if John Snow had said, It's interesting. This pump that is associated with cholera is in this poor community, while the wealthier communities are getting bottled water, whatever, and noticing those differences, and then helping to make sure that people who rely on public resources, as well as people who have access to private resources, still get the same access to opportunities to be well.
I'm sitting here and I'm thinking about all that we've talked about, and I just can't help but to say that in a world of a host of professionals who do work in public health and in medicine in general, I'm just glad there's you. Because, and I say that seriously, because I think that because what you bring to your work, just even in terms of you're talking about empathy and a concern for everyone getting the care that they need, is something that is very important. And what we don't see, and I think what we miss, is when we look at the table and see who's sitting there, folks with that capacity. And especially folks with that capacity who also have those various intersections of race, gender, class, sexual identity, disability, and all that stuff. Because if people aren't at the table with a very specific lens, then they're not going to always pay attention to people who need care or people who need better faucets, because they may just be thinking about their own neighborhood. So we've had this incredible conversation, and I am sure that there are some takeaways that we may want our listeners to have. What would those takeaways be for you?
As you were talking, the first thing that came to mind might seem completely out of left field, but it's that you matter, that your health matters, that you deserve not only good quality care from your individual providers, you deserve that. You also deserve research that reflects your real life lived experience, and you deserve a public health infrastructure that reflects your lived experience and your needs as a member of society.
I think that's a wonderful takeaway. I couldn't have said it better. I was thinking the same thing.
Were you?
Yes.
It's a synergy.
Oh, but I couldn't have said it as eloquently as you. So that's why you're Dr. Tonia Poteat. And why we have been so glad to have you on the podcast today. And we want to thank you for sharing in our Black lesbian herstory.
Thank you. It's been a pleasure.
It's not every day you get to have a conversation with a public health rock star, and that indeed is who Tonia Poteat is. We so appreciate her stopping by and spending some time with us talking about the importance of public health research and how we as Black lesbians can be a part of that work. If you would like some more information about the research opportunity she mentioned, be sure to check our show notes. As always, we so appreciate your being part of our listening audience. Have you subscribed to our podcast? Now, I've been saying that for the past few episodes, and you've had plenty of opportunities. So if you've not done it, go now to iTunes or wherever you receive your podcast episodes and subscribe to the podcast. We want to know you are listening. And while you're there, go ahead and rate the episode. I think we're worthy of a 5-star and a few comments from you. If you like what you hear or you want to give me some feedback, feel free to email me directly at podcast, podcast, @ZAMINOBLA.org. As always, thanks for listening. And until next time, have a sweet one.